triple. Healthcare will increase tremendously in the area of care for elderly people, and especially also in the field of comorbidities, and especially our comorbidity that is actually metabolic health. There will in the general population be an enormous increase. And what is actually then the situation in psoriasis and elderly? We know that in people younger than 70 years, that hypertension, dyslipidemia, diabetes, and MACE are increased as compared to non-psoriatic persons. But in people more than 70 years of age and having psoriasis, we see that it is more normal there to have actually an abnormality in metabolic health than to be normal in this respect. And that means that when we are dealing with patients with psoriasis, in elderly patients with psoriasis, that we should pay attention to metabolic health. In contrast to the common belief, where in the past I have learned, well, when people are elderly, then the quality of life issue is not so much anymore an issue for patients with psoriasis. And on the contrary, actually in people who are elderly, actually the issues regarding quality of life are even more expressed. And what is it that actually is so important to pay attention to? That is, doctor, I would like to sleep better, or then to be less dependent on doctors and clinical visits. It's come to you as taking me a lot of effort. To have fewer side effects and to have confidence in the therapy. That are issues which are very important. So in elderly patients, we have to strive for optimal treatment. We have to be ambitious. And let's now go to the treatments. Topicals, phototherapy, classical systemics first. Well, phototherapy and topical therapy can be administered in elderly people, but might be too stressful for some of them. And some of them is important. For treatment of elderly patients is personalized care. You have to know your patients well, what they can do, and what the load can be for a patient with respect to the treatment. Astatine can be administered in elderly patients on the same dosing schedule as younger patients. However, serum lipids and liver enzymes should be monitored. Cyclosporin should be used with caution in patients with possible renal impairment and hypertension. Look at the comorbidities and do personalized care. Methotrexate requires some precaution in elderly people. Methotrexate is a time-honored treatment, but it is important that you adhere well to the guidelines in order to provide a safe treatment. And in elderly, we have to pay attention to the following. There can be predisposing factors for bone marrow suppression. That's concomitant use of NSAIDs, immunosuppressants, liver disease, underlying renal function impairment, low albumin, and dehydration. And it's important to pay attention to that. And further, the serum creatinine, a marker to assess renal function. This is important renal function, for we know that the kidney is important in the elimination of methotrexate for the body. And when you have an impaired kidney functioning, actually your methotrexate levels may go up. Older patients with less muscle mass may have low creatinine levels, leading to overestimating their true renal function. And now to biologics and small molecules. When considering biologics in elderly, the available literature on safety and efficacy supports the use of these agents in this population. Be prudent in screening before initiating biologics and monitoring patients more closely, as elderly have a higher baseline burden of comorbid condition. Well, deucravacitinib, there's limited experience so far in elderly and has no warnings regarding elderly. And apremilast, take notice of diarrhea, nausea, and vomiting, which can be a problem in elderly people. But what do we see? We actually see that with aging, with every year's increase in age, the chance that you get a biologic is decreasing. So in real practice, actually, dermatologists are reluctant, actually, to prescribe biologics. And that's a shame for reason that elderly people need adequate treatment. What's the evidence available? A systematic literature review has been done to examine the safety and efficacy of biologic agents approved for plaque psoriasis in elderly. 18 articles met the screening criteria, but actually this work was some time ago. So the biologics studied were infliximab, etanercept, adalimumab, and secukinumab, and ustekinumab. Across all biologic classes, efficacy for biologics between younger and adult patients and elderly patients was similar. And then adverse events and infections occurred at a similar frequency between both groups. However, serious adverse events and discontinuations due to adverse events were more common in elderly. However, of course, during the preparation of this talk, I looked to the original article, and actually these serious adverse events were all over the place and had not the typical distribution of adverse effects where you would think about the biologics. And therefore also the authors support the use of these agents in this population. There's a very nice study, a small study, on the efficacy and safety of IL-17 and IL-23 inhibitors in elderly people with plaque psoriasis. It is a retrospective study. It's a somewhat small study, 128 patients. And at week 52, the improvement rates were similar comparing younger and adult patients. So for efficacy, no difference between older and younger. Infections were the most frequently observed adverse events in both groups, and notably urinary tract infections were slightly more common among older patients, but I would be surprised when that would not be the outcome of that study, for urinary tract infections in elderly people are more frequent. Although no serious adverse effects leading to discontinuation were observed among patients aged more than 65 years, 2 individuals younger than 65 discontinued treatment. Real-world safety efficacy biologics in elderly patients with psoriasis. This is a multi-center observational study in Japan. It's a somewhat larger analysis, and the outcome is the following. Treatment ending adverse events occurred in 15% and 11% of elderly and younger patients. No significant difference in the frequency of infectious diseases between young and old. Nevertheless, infectious diseases were more prevalent in elderly patients than in younger patients. And overall, the authors confirmed the appropriateness of using biologics in elderly patients with regard to safety and efficacy. It's a short presentation, so I would like to come now to a summary. Firstly, keep in mind, comorbidities are very common in older patients with psoriasis, most notably arterial hypertension, dyslipidemia, diabetes, and MACE. We cannot go around that. And psoriasis is an independent risk factor here, and we see that in elderly patients. Psoriasis may also impose a greater quality of life burden in elderly patients, but they are less likely to receive biologic treatment for psoriasis than younger patients, and that's a shame. We should change that. Management of psoriasis in elderly patients influenced by multiple factors: comorbidities, polypharmacy, adverse events, risk factors, and self-care. And therefore, personalized care is so important in elderly patients. And the approach to that is real-world evidence studies. Not so much a well-designed, neat clinical trial, but we need real-world evidence of the registries to inform us continuously on actually the care for elderly patients where a personalized approach is important. With respect to the treatment of elderly with biologics, efficacy and safety are comparable with younger patients. And awareness is needed of a higher baseline burden of comorbid conditions, and therefore, in our elderly patients with psoriasis, we have to monitor them well and treat them well and be ambitious. Thank you very much.
Thank you very much, Peter. Maybe time for one short question. Okay, I'll do it. So after listening to your presentation, so age when thinking about prescribing a targeted drug, a biologic therapy, is a restriction or maybe it's an incentive to do it. So it's a positive effect to do it.
Sorry, I didn't hear quite well.
Yes, so age, when you intend to prescribe a biologic therapy, yes, age is a barrier or maybe is an incentive. So to have an older patient incentivate to prescribe biologic therapy.
Yes, my personal opinion here is the following, that we have to be upfront here. And there is actually no evidence, but I should admit that the number of studies has to increase. We have to get more evidence, but the evidence so far does not give any restriction here with respect to the prescription of biologics in elderly. And when I look to the different biologics available, I would like to especially look at the anti-IL-70s, but even more to the anti-IL-23s as a very safe approach actually in the management. But it is important before you start any therapy in elderly people to be aware of comorbidities. And that is not selective for biologics, it's for all the treatments.
Okay,
yes?
Thank you. Okay, so now we move to case presentation related to special population, and it's my pleasure to introduce Priscilla Angwenyi. It's a consultant dermatologist at the dermatology unit of Kenyatta National Hospital. She's working in clinical practice, teaching medical students, and passionate and involved in advocacy for patients and patient education.
Thank you so much for that kind introduction. Good morning, everyone, and thank you to the IPC for giving me this honor to present on the special population. So I have no conflict of interest. I will be demonstrating on how psoriasis presents in skin of color particularly. Next. This is Nairobi and the hospital that I work in, Kenyatta National Hospital. As I've said, no conflict of interest. So I'll be presenting on a 46-year-old male who presented to our hospital complaining of scaly plaques since 2009. He says that they first began on the nape of his neck and gradually spread to his elbows, trunk, and lower limbs. He has associated pruritus, but no skin pain. In the past year, he has developed nail changes, but has no joint pain. He is married with 3 children, worked at a gas station as an attendant, but he's currently incarcerated and has been since April of this year. He smokes 3 cigarettes a day and has done so for the past 30 years. He does not take alcohol, and he reports no family history of psoriasis or similar skin disease. So he first presented to our hospital in May of this year with the scaly plaques, as I mentioned. We needed to do a skin biopsy, as that is what we do to confirm the diagnosis so that we can optimize treatment. All lab investigations were normal, including the metabolic screen, ECG, echo. Screen for hepatitis, HIV, TB were also negative. We initiated him on methotrexate 25 milligrams weekly with folic acid, and he has also been applying betamethasone ointment topically as and when he gets it. As I said, he's in prison, so access to certain medications are limited for him. He's also newly diagnosed hypertensive as of 2 months ago and has been on amlodipine 10 milligrams once daily. His BPs so far are well controlled. So this is how he presented when I saw him. He had these thick plaques in the occipital region of his, of his scalp. So very thick plaques, some gray scales, and even some papules. This is the lesion that actually bothers him the most. This is his left breast. He has this thick plaque, hyperpigmented, with very gray, thick scales. And this is his axilla. So he has this hyperpigmentation. There are areas of erythema, although with our skin type, it's often hard to tell. When there is erythema, it will often appear as hyperpigmented or purplish, but for his case in the axilla, we had the erythema. And this was his elbow with the scaling, erythema, and hyperpigmentation. His legs also bother him significantly. He's been on treatment for about 4 months now, but he feels we are not making much progress. Very dark brown with the scaling and very itchy. And this was a solitary plaque that I found on his back with the scaling. We can see some, what we describe as erythema in the darker skin type and the thick gray scales. His nails, he has onycholysis. He does have some ridges and pits, which I hope can be seen there and there, as well as the onycholysis that he's experiencing, but no joint pain so far. So he's been on the methotrexate, the erratic doses of betamethasone. He gets it whenever we have it available in the hospital or in the prison medical clinic. And we decided about this is a week ago that maybe we should optimize with some narrowband phototherapy, which we have in our hospital, as we consider if he is a candidate for biologic therapy. This is because the surface area that is involved is quite extensive, about 10%. What I took photos of is what he allowed me to. He explains his pruritus as very disruptive. He is unable to sleep well, and he feels extremely embarrassed by his skin. It's difficult to assess DLQI in a patient who is in prison, but he said prior to his incarceration, he felt very embarrassed, didn't know it would interfere with the social activities and the hobbies that he would engage himself in. So the challenges we are having, however, is stress. Could that be the reason why he's not responding as we would like? He's in prison. He's due to go to court, but he's unsure as to how the case will go. He still smokes cigarettes. I'm not sure where he gets them, given that he's in prison, but he's unwilling to stop. And he has the difficulty in accessing the topical agents that we would use normally. So we've brought in psychological counseling for the patient as we see the next steps towards his management. Thank you. That is the end of my presentation.
Thank you so much, Cristela. And we move to the next case presentation, and it's my pleasure to introduce Maria Julia Cura. Maria Julia Cura is a co-leader of the psoriasis team at the Department of Dermatology of the Hospital Italiano in Buenos Aires, Argentina. And she has been particularly engaged in clinical research. She's performing a clinical master. She has prizes, and we have her as an IPC junior counselor.
Thank you for the introduction. It's a pleasure to be here today. Well, regarding psoriasis in the elderly, our patient was a 17 70-year-old man, and as you can see, his medical history was complex. He had multiple comorbidities, typical for this stage of life. But especially chronic kidney disease was a real challenge for us for treatment planning. He was taking several medications, and his psoriasis started since adolescence, and over the years, he received systemic conventional therapies as well as phototherapy. Following the diagnosis of a high-grade urothelial carcinoma that required intravesical BCG, our therapeutical approach needed to change. And indeed, the patient had a flare-up of his psoriasis with erythematous scaly plaques on his low back, elbows, and also he has high-impact areas, involvement such as scalp and nails. So taking all these factors into account, we decided to start apremilast, adjust to his renal function. At first, the treatment was satisfactory. His skin improves, but after a year of apremilast, he lost efficacy and the PASI increased. So at that moment, it was necessary to start a biologic. So we performed some complementary studies, and we found an increased hematocrit and things that we had already known about his chronic kidney disease. But his tuberculin skin test was positive, something that is usual in Argentina, and both the chest X-ray and the CT scan were abnormal. This was the main challenge. We had to decide if the patient had an active tuberculosis, a latent tuberculosis in someone who had a chronic obstructive pulmonary disease, or if these changes could be related with intravesical BCG. Once active tuberculosis was ruled out, the infectious disease team recommended us starting prophylaxis for latent tuberculosis, and then we start risankizumab. This was evolution of the skin with a clear improvement over the weeks. But after 1.5 years, the patient developed eczematous skin lesions. So in that moment, we start suspecting a flip-flop phenomenon. The skin biopsy revealed subacute eczema. So we switched to deucravacitinib. But 8 weeks later, the patient contacted me with worsening pruritus, further extension of the lesions, but what really called my attention was the purpuric appearance of his plaques. At the same time, his hematologist, during a routine follow-up, found anemia, leukopenia, thrombocytopenia, and she decided to perform a bone marrow biopsy, and the diagnosis of acute myeloid leukemia was made. So deucravacitinib was stopped, and he initiated treatment for his leukemia. Despite all efforts, multiple infectious complications occurred, and the patient passed away 4 months after the diagnosis of the leukemia. So psoriasis is a prevalent disease, and as in many parts of the world, the demographic composition of Argentina is changing, and with the increasing of life expectancy, the proportion of elderly people is increasing. The main challenges in this stage of life are comorbidities, polypharmacy that increase the risk of drug interactions, the greater chance of other events, and overall frailty. Something that everybody knows is that elderly patients are underrepresented in clinical trials, so most of the evidence comes from real-world studies. These are the results of the BADVIT registry, and as we can see, elderly people had a greater chance to switch biologics due to adverse events. Another important thing is consensus, and in this point, the Spanish working group has been pioneer because they made a management recommendations for these special situations. In conclusion, treating psoriasis in the elderly is challenging, but people with moderate to severe psoriasis still need systemic treatment, so it's important to individualize the risk and the comorbidities. As evidence comes mainly from real-world studies, we need to share our clinical experience. The other important things to the end of the presentation is that we need to continue working together to build guidelines that may help us in treating special situations like psoriasis in the elderly. Thank you very much for your attention.
Okay, so thank you so much, my co-chair, Hira, and all the faculty for the excellent presentations today. So they remind us that psoriasis remains a very interesting condition of great relevance with many challenges today still to address and much to teach us. We have seen how, while the clinical diagnosis of psoriasis is usually easy, not everything that looks like psoriasis truly is. We have review of symptoms such as itch and pain, sometimes overlooked in psoriasis. They remind us other dermatological conditions can be highly relevant in decision making. We also need to remain aware of special populations. It's not only skin of color, it's characteristic of the plaques, distribution, impact on quality of life, availability of therapies in different parts of the world. So we have seen that elderly patients where comorbidities and polypharmacy complicated management have to be specially addressed. And at this point, biologic target therapy appears to be a good option. And finally, certain manifestations like nail psoriasis are still not adequately captured by prompts, so we must continue to refine how we meet patient real needs. So that's been closing remarks. So many thanks for coming here. I would like to, I think that we should have a QR in order to answer a very short survey. Thank you so much and have a very profitable meeting. Thank you so much.